I'm Adrienne Lindsay. I'm the director for the Center for Substance Use Training and Telementoring here at BeWell, Texas. Welcome to our TxSUS session. For those of you who don't know, our TxSUS sessions are webinars leading up to our annual symposium, the TxSUS Substance Use Symposium. It's just a means for us to stay connected between the symposia, keep up on emerging issues, and network with one another. So today we're going to be covering Texas rural health challenges, opportunities, and the role of hospitals. A couple quick housekeeping items. Feel free to connect with each other in the chat. I know you all are great about that. Have a conversation about the content. If you'd like to put any questions in, please put those in the Q&A box. That'll help us have those all queued up for the end of the webinar, some time that we left for discussion. No, this session will also be recorded, so if the content was helpful to you, it'll be on our TxSUS website. It will be on our YouTube page, and you can share it with colleagues. Next slide. Just a couple quick disclosures. The views and opinions expressed by our speaker today don't necessarily reflect TxSUS or the official policy or position of UT Health San Antonio. Okay, so I want to introduce our speaker, Terry Scoggin. Terry's a healthcare executive with more than 30 years of financial and leadership experience. He's focused on his passion for rural communities. He most recently served as interim president and CEO of the Texas Organization of Rural and Community Hospitals, which you all probably know of as TORCH, advocating for 156 rural hospitals across Texas. He currently consults on strategies that strengthen policy, operations, and sustainability in rural healthcare. And I know he has a lot of great content for you today, so we don't want to take up any more of his time. Again, we'll save some time for discussion at the end, and now I'll turn it over to Terry for his presentation.
Good morning. Thank you, or good afternoon now. Thank you so much for the opportunity. Let me share my screen real quick. I'm going to press this button, and then I'm going to do this again. And I think we're good to go.
Yes.
Okay. So real quick, no conflicts or disclosures of this presentation. And it's a friend of mine in East Texas, so we're good pals from that one. You will see some of my rural love throughout this presentation and some of the selections of pictures. And nothing better this morning when I went up, got to go to Bible study early, and I go to the pasture and see my friends in Northeast Texas as well. Here are our learning objectives, and we're going to talk about, I think you've had these already, and they're in the slide deck that'll be provided to you from that. And today I want to talk about the story of rural. And just so we're on the same page, I was born in Austin, moved to Palestine, Texas, in Northeast Texas, went to high school and junior high and all that stuff. Went to Texas A&M, graduated in 1992 with a degree in accounting, was in the Aggie Band, Corps of Cadets. Moved to Austin and started a family in Austin. Worked in high tech for about 12 years as a CPA and loved it, and was able to do a lot of great things in the Austin area. In 2004, I had boys who were 8, 6, and 4. Took a 50% pay cut and moved to Mount Pleasant, Texas. I wanted to raise my boys in the environment that I was raised. In Austin, it was a great place, but they had school friends, neighborhood friends, church friends, sports friends, and Cub Scout friends. So in East Texas, they have friends. And that's what I grew up with. So I wanted them to experience some of the things that I did. And been in East Texas since 2004 at Mount Pleasant. I joined the hospital, TxSUS Regional Medical Center, in 2012 as a CFO. Been in a lot of different high-tech industries, worked for Dell Computers, Motorola, seen some really cool things. Never had a job like I have in healthcare. Healthcare is, no offense to banking or accounting, one of the few jobs where a CPA can save lives. And TxSUS Regional is the largest independent rural hospital in Northeast Texas, one of the last independents left east of I-35. And just had a great experience. Been there 12, 13 years, and recently stepped down to go see other hospitals, and was working in Greenville as a CFO when Torch called me. It was my dream job, and asked me to serve as the interim CEO while John Henderson did a project for the governor that we're going to talk about today. And so right now I'm just so excited to share. But and what's funny is the gentleman on the right of this picture is Art Sharlock. He's the guy who hired me in 2004. Art is a friend, a mentor, ran the bank in town, looked at my resume in 2012, and I'd had 4 jobs, really good jobs over 12 years, and promoted every time. He looked at my resume and said, "You jump around a lot, son." And he says, "What makes me think that you're going to stay in this job for a long term?" And I said, "Sir, I've got promoted." And he said, "No, we don't do that in East Texas. We stay in one place for a while." So, and that was what started my journey back in rural. Rural's personal. In rural Texas and rural America, you go to church, you go to school, you go to sporting events, you go to Walmart with the same people. So in the hospital, that's what you get into. And for a rural community, I want to, just for you to understand the rural atmosphere, for a rural community to be economic successful, we like to look at the 3-legged stool. You need all 3 legs for your economy to be just to survive and thrive. You need 3. And those are good schools, good churches, and good hospitals. And you have to have good health care if you want an economic. So an economic board in a community, if they want to go get new business, they have to have all 3. And without one of those legs, you hurt. And that's one of the things that we're really focusing on now. Rural Texas is big. And I was just on the phone before this call with American Hospital Association talking about rural and just walking through the differences. But there's 254 counties in Texas. The HHSC defines rural as a county of greater than 68,750. Texas is different. The federal government has a different definition, but for Texas, it's a county of less than 68,750 is rural. 80% of Texas is rural. 201 counties across Texas are rural. There's 139 counties that have hospitals of those 201 rural ones. So, 70%. So there's a large portion of Texas who doesn't have a hospital. I know in East Texas where I live, 3 of the 4 counties that touch TxSUS don't have a hospital. So Texas has a lot of challenges we're going to talk about today. But there's about 12% of the population of Texas is rural. More than 21 states Texas rural is larger than 21 states, our population, which is crazy when you think about it. We're an older population, and we're a sicker population. We're going to talk about that today. I love this slide to kind of just give you a little bit of understanding of rural. And I don't know if my screen shows up with you guys, so I'm just going to move it. But here's Texas, and you can see the darker is your larger counties from a population standpoint. If you look at West Texas, very small, and there is a county with 52 people. But you can see how sparse West Texas and the Panhandle, and you can see I-35 right in the middle, and you can just tell all that stuff around the I-35 corridor in Houston from that. But there's 156 rural hospitals. 40% are PPS, or what we consider a normal hospital. It's fee for service. It's just like your regular hospitals, just normal hospital. You eat what you kill from that. 91 hospitals in Texas, of the 156, are critical access hospitals. These are cost-based hospitals, usually more than 25 miles from another hospital, usually. But it's a division or a classification given by the federal government to kind of help those smaller communities, census of 1 to 5 to 10. So a lot of your smaller rural hospitals are critical access. And then a new classification in Texas is rural emergency hospitals. These are new. And I think soapbox for one day, if you want to talk to me about it, I think there's going to be a growth of these. But they still see patients as observation, but there's no inpatient. There's none of the other things. It's an emergency department with observation and imaging and that. But you can kind of get a feel. Of the 156 rural hospitals, about 60% are independent and about 40% are owned by health systems. I'm an independent guy. I love independent hospitals. TxSUS is still one of the last independent, and I push for independence. And the reason why is I believe in community care. And no offense to larger health systems and stuff, but I believe in community control or local control. And really in all these counties that you see with smaller populations, I want the control and decisions to be made in those communities. They know what's best, not corporate headquarters in Tennessee or New York City or Dallas, but really at those local level. They know what they need. So I'm a believer in independent. Now, at the same time, you have to partner with the larger health systems, and I get that. just in case you're wondering, the larger health systems don't want to own the rural communities. I mean, it's tough. I mean, it's not a business model of a rural hospital. There's not many people paying millions and billions of dollars for rural hospitals. It's not a great service line if you're going to get into. But here's some things that are going on in the rural communities. You're going to live less. You're going to have a better life, in my opinion, but you're going to live less. And the Texas rural benchmark is those counties those 201 counties I talked about. That's the benchmark we created here. I use this tool to kind of get a lot of our data, but you can see 73.8. The Texas average is 76.7, and the national average is 77. So if you live in a rural community, you're choosing to live fewer lives. I love giving this slide. This is my boys. I live in Titus County, and the average is 74.5. My oldest lives in Round Rock, Williamson County, so he's going to live the oldest. My middle son is going to live in Pflugerville, just a little bit less, and my youngest is in Dallas from that. All three of my boys will outlive me a number of years because I choose to live in rural. So that's one of the things that I'm focused on, and a lot of the stuff we're talking about today is to really understand how do we keep rural healthcare sustainable, because it's not good for Texas. With 80% of Texas rural, we've got to find ways to make rural healthcare sustainable, viable, innovative, and those things. I love giving this example. This is Titus County where I live. So this is our county. The average life expectancy for Titus County is, in Titus County, I didn't explain earlier, I'm so sorry. We're 60 miles from the Oklahoma border, the Arkansas border, and the Louisiana border on I-30. So the northeast corner of Texas. So it's great. We get to see all these things around us. But 77.4 is the average for Titus County. If you live in the north part of town, it's 78.1. Well, that's where our country club is. 3 miles south is downtown, and a mile south of that is this part of town. 69 is the average life expectancy in those neighborhoods. So under a 5-mile radius, you have more than 10 to 12 to 13 years in life expectancy differences. And it's not going to surprise you that our largest employer is in that 69 region right there. It's our chicken processing plant. 500,000 chickens a day. I mean, processed. Just enormous amount of industry right there. However, there's a lot of poverty. There's no clinics over there. There's none of that type of stuff. So this is the type of data that I focused on as CEO, trying to understand and how do we fix that and what do we do for those communities. But I'm a big believer in social determinants of health, or in Texas, because they're different non-medical drivers of health. But this is the kind of stuff that I would encourage you to understand and to look at in your rural communities, and to understand this differences and because a lot of things are different. Just a quick slides that you'll have the data. You can go back and look at it, because as a CPA, I'm a data guru, but mortality rate in rural Texas, much higher than Texas and in the national average. Coronary heart, #1 cause of death in the United States, especially true in East Texas and rural Texas. And you can see what the Texas benchmark is there from there. Almost double what the healthy people target is for 2030, which is really challenging. Same thing with strokes. My first son was born when my wife had a stroke and preeclampsia. So I'm very familiar with strokes and what happens in that. But look at rural Texas, the number of deaths per stroke, still almost double what the goal for healthy people 2030 is from that one. Here's a sad one. And I was actually on the phone this morning at the University of Texas Tyler Medical School, doing some great things in rural maternal focuses, and we were talking, brainstorming some stuff. But here's the infant mortality. If you look at 2017 and 2022, United States and Texas, a drop of 5.6 to 5.5, but rural Texas went up over that same time frame. Horrible facts on data. But let's dive into that a little bit. It's always on the surface is one thing, but you got to dive into it. Here is a friend of mine in Tyler County, which is south of Tyler. It's not Tyler. Tyler is Smith County. But in East Texas, I did this for a friend of mine who's CEO in Woodville. And if you look at Tyler County, 6.4, it went to 7.5. The red line that you see there is Northeast Texas. So Texas is broken into health districts. There's 8 different health districts and regions in Texas, and that's where Titus County, where I live. We're in PHR 45 North. Look at that one, which is Tyler, Longview, all along the Arkansas-Louisiana border. 6.8 deaths per 1,000 for infant mortality, and it went up as well. So East Texas is really struggling with this, and different maternal deserts in East Texas. And that's what I was on the phone this morning, some things that are happening. But this is the kind of stuff I tell people all the time. In rural Texas, it's personal. And you've got to understand this. And once you see this data, you can't unsee it. Colorectal cancer, almost double from that. I will tell you, I got my master's in healthcare transformation from Texas in 2023. My thesis was colorectal cancer mortality for communities of color in rural communities. And part of that was getting my colonoscopy at 53. Well, lo and behold, I found I had colorectal cancer as part of my thesis. I found out I had colorectal cancer and then liver cancer. And so we had just at TxSUS switched from a very large for-profit cancer center to an independent our own cancer center. And I got to be one of the first patients, which was crazy. God has some crazy paths and stories, but it was unbelievable for me to be a part of that and go through cancer and just understand in a rural community what it looks like. Here's some of the things when we talk about, you live a shorter life, and you say, Terry, what are the reasons? Well, we're sicker and we're older. We're poorer, uninsured rates. But this is primary care, PCP. Look at Tyler. I like Tyler County and Woodville. Gives you a little bit more of a home feel, but because they're even less than what the rural benchmark of 35 physicians per 100,000. East Texas is 56, almost double. But then Texas, which is really, honestly, Texas is Austin, Dallas, Houston, San Antonio, and El Paso. That's that Texas number. So goes those 50 counties are very close to that Texas number. But you can see, look at East Texas, and then you can jump up to Texas, but then national. we're still lower. So primary care is going to be the future. We're going to talk about that today. I'm a big primary guy. Mental health. Look at the mental health in Tyler County and Woodville versus the rural providers, and East Texas, and then you get into Texas. You can say so. We've got mental health, and mental health. If people tell you mental health is not a problem in rural, they don't understand. They've got their eyes closed, and there's a lot of stuff going on now in that world. But here's some things. Texas has a large uninsured rate. In Titus County, where I live, we have a 34% uninsurance rate. We have 13% pediatric uninsured rate, which all children have insurance in Texas. Well, not in East Texas. We're about 13 to 14 compared to state average. But rural is just like the rest of the state, but then portions of the state, there's some large uninsured. But here's the difference, and one of the reasons for life expectancy from Texas. You have uninsured, yeah, but look at the poverty rate. The poverty rate, there's a bigger gap and below 150% of poverty between the rural benchmark in Texas. And, so you can just see the difference there. And then you get into some of those communities like Titus County, huge increase. There's just a lot of things when you peel back the onion of rural. Once you see it, you can't unsee it. And, I talk about, you say, Terry, why are we having the issues and hospital closures and stuff? It's expensive to be independent. And those 98 plus ish independent rural hospitals, that creates a lot of financial troubles and high uninsurance. It isn't helping. We have regulatory issues, older populations. Medicare Advantage it'll be recorded, so I have to be nice. But Medicare Advantage and Medicare Advantage, your rural communities are seeing a huge increase in Medicare Advantage. They don't pay the supplemental funding that traditional Medicare pays. There's a big difference in Medicare and Medicare Advantage. And most of your rural communities are going to be 50 to 60% Medicare and Medicaid, which means they pay below cost. A Medicare hospital, a good one, loses 3% on Medicare patients. So an independent rural is going to lose 5 to 10 on a Medicare patient. So those are the challenges that you run into. And we talk about financial closures, but I just kind of want you to understand there's been 195 closures since 2005. We've got, about 800 rural hospitals across the U.S. that are in verge of it, and Texas is one of them. But I love looking at this slide, and you see 2005 to 2010, 43 hospitals, 2010 to now, 152 rural hospital closures. So you say, Terry, is it the big hospitals, the small hospitals in rural? It's PPS and critical access. Those are your two big ones. I always thought it was PPS, and they're tweeners. And my thesis and research always says PPS until this is SHEPS data, which is really good data. The SHEPS Institute in North Carolina has great data. But it's mixed across the nation. Now in Texas, you're going to see more PPS hospitals. The critical accesses haven't seen as many closures in Texas, but across the nation, you see the fee for service and critical access about the same. Here's a great slide that shows you over the years. You can just see here's the hospitals by year. At 2014 and 2015 was a horrible time in rural healthcare. And in Texas, we had a lot of closures in that year. That was our largest year. Most of those closures, that 14, most of it was Texas. And if you look at the map here and right, the far northeast corner of Texas, across the 3 states, you can see all those blue clinics. Those are all around me. On December 31st, 2014, we had 4 hospitals closed within 35 miles. I was in Mount Vernon at midnight on December 30 or 6. We closed 6 p.m. We closed the hospital. Our hospital took over the EMS. So I went there, and it was one of the saddest things I've ever seen. And I don't want that to happen to any rural hospital, to lose it, because you can see Texas. Here's the 25 hospitals that have closed in Texas. You can see the years, and you just look at they're all throughout the state. A lot of it in that East Texas region, and a lot of closures in there. So, and a lot of poverty, a lot of other things in East Texas that caused that from that one. But I worry about the future of rural healthcare. And, this is done by the SHEPS group, and it's distressed. You can just see, especially in the South, there's a lot more hospitals at risk. And that's why, if we continue to look at it, and here's one of the biggest reasons is, closures of a hospital. I said a 3-legged stool. And when you lose one of those legs, you lose jobs. An RN makes between $16,000 to $85,000, $90,000. In a rural community, that's a great job. You lose 40 or 50 RNs, it's going to impact your sales tax, your docs leave. You lose your emergency department. No business is coming to a town without an emergency department. They're not going to bring industry if you don't have an emergency department. So you lose the ER, your travel goes up on people, and that's a burden. You don't have the investments in infrastructure. School enrollment goes down, house sales go down. I mean, these things, these dominoes happen, and you go from a vibrant, small community to a struggling Texas town. And that's the reason why we really focus on healthcare, and focus on things. And, in addition to the stuff I talk about, there's a lot of federal challenges. And I just put this slide in there, and no offense on the stallions running from there, but there's a lot of things that are helping the federal level that are hurting rural hospitals. Government shutdown really hurt us, and dish cuts and adjustments and telehealth and those things. Small adjustments to an urban hospital, life-threatening sustainability to a rural hospital. And I don't want to be Mr. Gloom and Doom and that stuff. There's so many good things happening in Texas rural right now. And Texas rural is a balance. And, I had the opportunity in my most recent job with Torch to travel a little bit and see all the hospitals in the Panhandle in West Texas. And there's challenges, but at the same time, there's a lot of good things going on. And I think we're at a crossroads in Texas where there's some great opportunities and great innovation. In September, the governor signed HB 18. I will tell you, the governor supports rural Texas, and his office supports rural Texas, and they do not want any more closures in rural communities, and neither do the urbans. Nobody wants it, but they're doing some great things over the last 2 and 3 legislatures to ensure Texas has more. Texas already has more rural hospitals than any other state in the United States, but they're doing things to make sure Texas catches back up and we can prevent these. So HB 18 was passed. September was signed. The governor had the opportunity to meet the governor and talk about it. This is going to help over the next 2 years, another $100 million for rural stabilization, focusing on investing in the infrastructure in these rural hospitals. And I say all the time, one of the things when I was traveling the last few months, I got a strong realization that it's just not rural hospitals that are struggling, it's rural communities. Several towns I visited had water and infrastructure issues. The hospital had to put water towers in order to ensure water because the community had water pipeline and sewage issues, and it would go down. The hospital would be without water. One of the hospitals I visited have a tank that the fire department comes once a week and fills the water to ensure that water's in the hospital that week. So it's just not hospital, it's rural communities. So as you think about opportunities to help rural health and that, don't lose the fact it's just not the hospital. It's these rural communities that need investment. HB 18 also, I'm so sorry. This is HB 3000. I have to fix my screen, but this is HB 3000 that was passed in the last legislature as well, which is for a rural EMSs. So all the rural hospital counties in Texas will have the opportunity to get grant funding for a new ambulance. Huge need in rural Texas. The new ambulance runs about $375,000. It's about a 2-year wait period. So those are the types of things that are big investments for rural that I think Texas is doing. So Texas is definitely putting their money where their mouth is when it comes to helping the rural communities. And 80% of Texas is rural from a geographic standpoint. Here's a new one that if you follow the news and a lot of things with the OB3, it's really a big, beautiful bill. Cool kids call it OB3. But part of that is a rural health transformation. There's going to be 150 trillion cut over the next years and things. And a lot of that is going to be felt in these rural communities. So to offset that, there's rural health transformation project was put in place. There's going to be $150 billion that's going to be cut. I said trillion is billion, my apologies. But we're going to put over 5 years, 50 billion back into rural healthcare to offset some of that 150 billion. Now, that 150 billion is going to hurt some of the states that expanded Medicaid and haven't done a lot of cuts. Texas has been very not expanding Medicaid and focusing on state funds and certain things. Texas is not going to see the impact that other states are going to see. But there's $50 billion coming in the next 5-6 years to rural communities across the United States. 25 billion will be split evenly across, no matter if you have Delaware, Rhode Island with two or three hospitals versus Texas and 156. It doesn't matter. You're going to get 25 billion spread to all the states equally. The other 25 billion is going to be a grant application, and that's where I went to Torch because John was asked to work for the governor's office and help with that application with HHSC, and they put together a great application because that other 25 billion is up for grabs. And next week or 2 weeks, December 31st, CMS will announce what states are getting the money. So huge opportunities with Texas to get some additional funding for innovation and really to rethink rural healthcare and infrastructure. This is from the same group in North Carolina, the Sheps group. They put together kind of the calculation that's in this rural health transformation. It's a competitive application. Part of it's going to be about scores and metrics. Here's their estimates of where the states fall out. They've got Texas at the highest of needs and meeting from a point standpoint when it comes to application. So that's good for us. They just look at the state characteristics and rural hospitals. So even though everybody's going to get 25 billion spread out, the next 25 will go to certain states who have certain things. And here's the application that HCCC put in. They budgeted $1 billion. I'm hoping to get 2.1, 2.2, and that would be huge for Texas. And here's kind of the buckets that the application that HCC summary they put out there, focusing on make rural Texas healthy again, primary care, chronic disease. I think that's the key to rural healthcare, is really focusing on primary care and getting those communities across the Texas, making sure we have the right chronic disease management. And rural communities have more than one comorbidity. So it's hypertension and diabetes, smoking, overweight. Unfortunately, I look like rural Texas. And some of my health problems, and I'm trying to get healthier as well, and have been for the last few years. But there's a lot of those things in chronic disease management. Going to focus on AI, going to focus on innovation, some things with workforce, and trying to do some things to get more doctors in those communities, or providers, not just doctors. But you can see this is the application that Texas has. There's a portion for infrastructure, and that will go. But if you take House Bill 18 and you take OB3, you're looking at billions, several hundred million coming to Texas rural. That I think really we're at that crossroads I talk about. That even though there's some challenges in rural communities, we've got some great opportunities. Now, where I want to make sure people, and I'm really got my soapbox going, is we get one shot at this. and you got $2 billion possibly coming to Texas. We got to make sure we use our money right. We've got to make sure we set up rural Texas for the future, and we don't look back in 5 years and say, we got some checks and we just wasted it from that piece of it. Oh, my apologies, I got shorter. Um, so as you can see, there's challenges in Texas rural, but there's also some great things coming when you look at all of them. And Texas has some great resources. I think Texas leads the nation in rural healthcare, and some things that we're doing in Texas, I think a lot of other states are jealous of. We have one of them's Torch, and I had the opportunity to lead Torch for 75 days, and I just loved it. It was my dream job. Torch represents those 156 rural hospitals, advocacy at the state and federal level, but really tries to provide things to help those rural hospitals work together, focus on the needs of the community, and make sure the state understands here's what they need. And so Torch is a great organization. John Henderson is on my Mount Rushmore of rural healthcare, brilliant individual and does a lot of great things. Another one is the universities. It's really cool to see. If you have any questions, put them in the questions and answers, and we'll get done in just a minute. I'd love to chat about your questions and get those. So put those out there in the questions. But the universities are getting involved with all the money starting to come between the legislative teams and the Texas and the OB3. You're starting to see a lot of new people come to the table to talk about rural healthcare. And a lot of your universities and different partners are now really getting involved. This is Texas Tech's involvement. Texas Tech and Torch. In the 2023 legislature, we put together a pilot program of emergency telepsychiatry in rural communities. And Titus was the pilot for that. Titus has a lot of mental health challenges because it's the only hospital, the 4 counties that go around. So 5 counties, they were really supporting the mental health. So it wasn't abnormal to see 4 to 5 patients in the ED constantly for mental health. And the average length of stay was anywhere between 2 and 3 days. And the hospitalization rate for mental health was almost 95, 96%. The longest gentleman while I was there 6 weeks. Can you imagine being in a emergency department room, mental health issues for 6 weeks with no care? And the problem is, just so you understand, emergency doctors are great. They're not trained in the psychotic drugs. The drugs that get involved that these people are already on, it's very tough. So a lot of it is medicine management. So Texas Tech partnered with Torch and created this in the 2023 legislature. 2025, they did it again and re-upped it. And so any rural hospital in Texas can be on the network, 7 a to 7 p. It's telepsych. So I'm going to talk about Titus for a second. Once they turned it on in April 2024, they went from a 95 to 96% hospitalization rate to less than 40%. Over half the mental health patients coming to ED now go home instead of going to a state hospital. It's just amazing that the work that they've got from that. Oh, I lost the slide. Oh, there's a slide. So I'll come back to it. But here's the rural telehealth sites. And you can just see there's 23 hospitals now. There's another 10, 15 that are in the works. But you can really see that those telepsych hospitals are starting to make progress in the rural communities in West Texas. It's going to be a huge opportunity to try and discharge these patients from there. Another group that's doing within Torch is the Clinical Integrated Network. Torch has formed, there's 42 hospitals. Majority of them are in that 98 independent hospitals we talked about earlier. So about half the independent hospitals in Texas are part of the Torch Clinical Integrated Network. And what this is an opportunity for Torch members and the CIN to act as a health system. When you're one of the reasons why rural hospitals struggle is commercial contracts. We get paid between 2 and 3 times less than our urban counterparts for the same procedures. And if I'm a hospital system in a rural community, they're getting 2 and 3 times because they've got somebody negotiating them at the system level. So it really creates for that commercial rate, and that's 20 to 30 to 40% of your payer mix. You're losing money because I'm one hospital. So I call one of the large insurance companies and say, my rates are horrible. And they say, so they don't negotiate in the past. Now they're starting to negotiate because they realize that rural hospital closures, these urban hospitals are going to take over, and their rates are 3 times. So you're starting to see that crossroads as well. But there's a lot of little hospitals that can't negotiate. This clinical integrated network is going to allow the rural hospitals to collaborate and do things from that one. The other one, the University of Texas is really doing some things with the Texas Child Mental Health Consortium. Great work that's being done with CPAN, PeriPan, TChat. There's a lot of good work on children's mental health that's been started over the last few years. So a lot of good work's happening there. You see, from a standpoint, Texas A&M and their Rural Community Institute, Archie, they're starting to focus on certain things. Maternal health's a big one they're working on, trying to figure out some economic stabilizers. I'm working a little bit with them. But you see the University of Texas coming to the table, A&M coming to the table, Texas Tech coming to the table. Texas State is going to be part of, in HB18, there was a rural CF Financial Leadership Academy that Texas State and all the players are going to be in. So you can really see it's just not the rural hospitals working alone or Torch looking alone. You also have the State Office of Rural Health that's going. So there's a lot of partners that are coming to the table. So again, that's the kind of things that it's just not one institution. It's not those things. And the other thing that's starting to come to the table that makes me so positive about the future for rural health, it's innovation and an AI. And I will tell you, rural hospitals, if we're going to stay sustainable, we have to adapt innovative practices. And at TxSUS, we did a deal in 2017 to get on Epic and partnered with Ochsner in New Orleans and used their Epic. But MyChart is just an unbelievable tool. We have to continue to do those things in rural community, and it's going to take collaboration to really get that stuff done. But if we're going to be sustainable, if we want to take those monies from OB3 and rural health, we've got to focus on some innovative practices. And phone call I was on this morning was focused on data and data lakes and opportunities to really get data-driven opportunities in rural. And I think that's going to be, one of our key foundational opportunities to really focus on the AI piece and using data. I'm a big data guy. There's a lot of challenges with data. We don't need more data. I'm telling you right now, we have plenty of data. It's how do we make the data interactive and useful. And rural communities are very fractured and segmented on the rural hospitals, where health systems have it all in one place. So, that's the things that we really need to work on. I'm really hoping with OB3 and Texas's application, we'll be able to really focus on some of that data and consolidate the rural communities into one entity and have them take advantage of some stuff. So there's a lot of great things going on in rural, and I think the state is way supportive of rural. People say all the time they're not, but no. And my opportunity at Torch allowed me to see how the sausage was made, and I got to do advocacy and talk to the legislative teams. And there's so many legislators, even in urban communities, that are supportive of it. And once you show them the data, once they see these hospitals who can't get water, once they see that infant mortality, once they see Blue Cross or a payer is paying half to a rural community what an urban is, they want to get involved and they want to help. So University of Texas is also doing a policy, and the project that they're working on is focused on 2027, and they've made rural health the focus of their policy for 2027, which is a huge win for the rural communities. So, that's all I've got. Would love to spend a few minutes answering some questions. I'm going to stop sharing, but would love to open it up to questions and hit me with your. I'm an open book, so you can ask me anything.
Thank you, Terry. It was very, very informative. We have some questions flowing in here, in no particular order, but starting with one from Karma. What do you see as the role of standalone ERs or urgent care centers in rural areas that have experienced hospital closures?
Well, you need the problem with your freestanding ERs. Most of the time, you're not going to see a freestanding ER for rural hospital closure because a lot of your freestanding are done by for-profits, and they're charging higher rates. They may or may not take Medicare. So a lot of your rural community, there's not a lot of freestanding emergency departments. So they're not happening. So that's why I think the rural emergency hospital, because you're going to get some charity work in those, I think it's going to help it. But most of the time, the freestanding ERs are competitive of the independent rural hospitals in some of these communities. So it's a very tough environment for those freestanding. Urgent care centers are definitely opportunities. And again, it's getting the right care at the right place. And in Titus, and what we suffered from in 2012 and 13 was 40% of our ED visits were level fours and level fives, from a trauma analysis standpoint, not from a billing. So it's primary care. It's less than one nurse. You didn't even see a doctor. We took some money in 2012 in the district program and opened up a clinic that was open 364 days a year, extended hours. Again, we dropped that from 40 to 25 to 28%. So that's really the urgent cares and your primary cares. I think a focus in your rural communities, those needs to be primary care. We need to focus on that 80% of healthcare is associated with primary care, social determinants of health, food insecurity, transportation, poverty, housing, mental health. Those are the things that I really think that it's going to be a bigger impact than your urgent cares and your freestanding EDs. The ones that close hospitals, most of them don't have an ED, and we've looked at some of those areas for in freestanding ERs, and they don't want to touch them because they're not making money, and that's one of the reasons why they closed down. The REH, the problems with REHs right now, and this was a conversation I had this morning, was you lose your critical access designation and you can't go back. So a lot of hospitals are concerned about going REH. If it doesn't work, can they go back to their critical access? And they can't. You also lose 340B, which is a big financial impact from some of these communities. So CMS and the federal government have some work to do on REHs to make it. I will tell you though, in the big beautiful, it's a great question because the big beautiful bill, the House's bill had the opportunity for you to go back 15 years and say, if you were closed, you can open back up as an REH. I had 4 communities that reached out to me. We were ready to do it. Senate didn't pass it, but I think that's the future. These hospitals that have closures, they would love to have a rural, the ones that closed would love to have a rural emergency hospital. Because if you've got to go 25 miles for an emergency department, that's what Mount Vernon, Texas has to go 20 miles to the nearest one. It's horrible. You don't want that in your community.
Thanks, Terry. A couple other ones coming in here. How do FQHCs fit into this picture? I know we talked a little bit about urgent cares and
Well, in
ERs.
Texas, rural. So you have regular clinics that are primary care clinics that are global. You also have rural health clinics. So if you meet a rural health clinic designation, so a lot of the rural hospitals in Texas have RHCs, and there's a lot of growth happening in RHCs. Then you have the FQHCs. RHCs are state programs and state funding. The FQHCs are federal funding and federal rules. FQHCs are usually have a lot more red tape to form. FQHCs are really good in some communities. FQHCs also have some corporations that own them. And, not all FQHCs are created equal. Similar to RHCs too, but for the most part, FQHCs are going to have to play a part in this from that one. I get a little concerned about some of the corporate FQHCs in rural communities that they're not investing the money back in because they're a for-profit corporation investing money in other areas. So the dollars made in that community don't stay in that community. But FQHCs that are independent and really have that rural focus are doing some great work. So I think, but we need FQHCs. We need RHCs, FQHCs, and rural hospitals. I didn't talk about, though, one of the things I think that's missing in rural communities is public health. And Northeast Texas, there's 35 counties, 26 don't have a health department, an independent health department. That's all done at the regional level. 9 have independents. I do think those community hospitals are focused on the public health piece. And I think that's one of the changes you're going to have to see in Texas is really focus on how can you focus on these counties that don't have health departments to really use the rural hospital to be the health department. But FQHCs are part of that solution as well.
Great, thank you. One other question that came in that sounds like it was just a clarifying point from something you said earlier. You mentioned someone sitting in the hospital for up to 6 weeks with no care. So they were asking, they were just finding that hard to comprehend that something like that could
So
happen.
let me rephrase it. A mental health patient 6 weeks with not a psychiatrist or
Okay.
mental health care. So, and again, understand that emergency department room has no TV. That emergency department room has, it's just a small room, uh, 10 by 10, maybe. I mean, it's small. You don't have, you're getting your meals, but rural hospitals don't have adult or children psychiatric units. They may have a geriatric, but they don't have it. And if you don't have insurance, you have to go to state hospitals. The state hospitals in Texas, Mount Pleasant, it's really a forensic hospital that takes care of all the hospitals in Dallas that send to there. So it's weeks to get into a state hospital. If you don't have insurance, it's hard to find a place. And so they receive medical care every day. But that wasn't the problem. The problem was mental health. And there's nobody that can help them with their drugs, making sure. And a lot of times it's medical management. What's the right medication and getting the medication balanced and that. And emergency departments, physicians don't have that training. So they got medical care, they didn't get psychiatric care. And now they are. With a rural telehealth psychiatry, they're getting it. It's a great program. I want to see it in all 98 independent hospitals. I think we'll get there by the end of 2027. But it's a great program that Texas invested in. And you've got that one going for the emergency departments. You've got the Mental Health Consortium, CPAN, PeriPAN going for your outpatient children and more postpartum and those things. So a lot of good things are starting to happen in mental health across Texas and the rural communities. And CPAN and PeriPAN, that's across the state. That's not. And that one's also with CTAT, I think is the name. It's getting into the school systems too. Great program that the consortium's doing. And it's really going to benefit rural communities as well.
Great. Thank you. And just an offshoot to the psychiatric and mental health needs. Many of us on this call work in the substance use field, and something we're routinely hearing from rural hospitals is, maybe some of the docs not quite being ready to prescribe buprenorphine, or maybe having some hesitation or some stigma, or just not quite sure what to do there. Also the concern of, okay, so we identify someone with a substance use disorder, but we have no one to refer them to in our local area. Many of us are actively working on this, so not to imply there aren't things being done, including here at the Be Well Institute. But what are your thoughts? Fresh ideas? How do we begin to address these SUD challenges and
yes, to your things, and it's really a challenge, and I think that's what one of the things we've got to focus is substance abuse, because when you look at it, especially in the 5 counties around where I live, it's huge, and one of the major issues in your jails and that stuff is doing this. So we have to continue. We got to use It's going to be a telehealth solution. It has to be. I want to be first. I'll say telehealth is not the silver bullet. Telehealth will not fix anything. But telehealth as a resource can really do some things. We've got some work to do with substance abuse, and I think there's some stigma in rural communities about substance abuse and things. But let's be clear. 10 years ago, there was a stigma around mental health in rural communities, and now everybody realizes, yes, we have mental health in rural communities. So people are now we have a high suicide rate among farmers. We're starting to see that now in mental health. So now is the time to also start focusing on the substance abuse stuff. And you're starting to see that more. We've got a lot of work to do, Adrian. We got a lot of work to do with substance abuse and that. And I think that's education. And I really think, and I see Michelle's on here and she's going to get another one, but the work that the mental health's doing in the younger is going to help us with the substance abuse in the adolescence. It doesn't help us today. It doesn't stop the bleeding, but if we start getting that mental health help and mental health in the schools too, education wise, I think that's going to help our substance abuse problems as they get into that. One of many, but we still have a gap that, and I didn't mention maternal health. Maternal health's an issue across those 201 rural communities. Less than 40 of those 201 counties have deliver babies now. Unbelievable risk that are going on in the maternal health world. So we've got a lot of work to do. Mental health and maternal health, I don't think there's going to be a lot of investment in the OB3, but there's going to be a huge amount of investment in HB 18 and state funds related to maternal health and mental health. The state, I think, is really stepping up to build a solid mental health solution. substance abuse has to be focused on rural communities. And I think it's a great ask. And I think that's something you guys, I look forward to seeing some of the solutions focused on the substance abuse piece.
Thanks, Terry. I think we have time for maybe one or two more questions. There's some really good ones coming in here. When it comes to data, how you leverage it, could you talk a little bit about how and if the statewide HIE data can be leveraged to support rural health communities?
So it's much more than HIE because Texas, well, first of all, if you don't go research Texas and HIE, it's a disaster. There's 8 to 9 health information change, and it's tough. And there's been investments in HIEs for even Texas HSCs, a group that I work closely with from that. I think where data needs to come into is kind of, we worked with Oshner in New Orleans, really, you're going to have to create a rural data lake in infrastructure. And I think there's opportunities, and there's some work. Microsoft's involved now with Texas and some other things. But from a data perspective, rural hospitals are fragmented and broken when it comes to data. And it's hard to get stuff out of the EMRs, and it's hard to get claims data. It's hard to get these things. I think there's an opportunity with that money and that 2.1 billion that we're going to get is to take a portion of it and build the infrastructure needed for a complete data lake, and really focusing on the universities and the rural communities and the claims and the education. I truly believe that's the foundation for our innovation. It's not, no offense, it's not drones and it's not just telehealth, but we really have to use these next 5 years to get a solid data infrastructure and use AI with the data to help us identify, what are the opportunities from different types of chronic disease management. We've got to focus on primary care. And I think primary care and social determinants of health or non-medical drivers, data, I think, can help us with that and focus on what areas, what I showed that one slide that shows you when you break down Titus County. So if you just use data, you're going to say, oh my gosh, Titus County's fine. But then when you use all the different types of data, you realize, no, we've got a segment in Titus County that's living 15 years less than this other segment. And I think that's why a focus on data, I'm a data guy, and everybody wants to have a decision support system. It ain't easy. And data is, it is a big challenge, but I do think right now is that crossroads that I think we can use some of this money to use these next 5 years to build an AI generated rural Texas focus, and then take that clinical integrated network and use it there from that one. I get excited about data, by the way. I'm a CPA. Come on. I mean,
Well,
hey, real quick, can I tell you this though? Just for the people in this call, don't discount people in rural communities and older people. They will use my chart. They will use their cell phones. Don't think for a minute that it's a bunch of ignorant rednecks like me or something like that. And the older communities won't use tele. No, they will. They'll use AI. My mom is 80 years old. She calls me 4 times a day. She lives close to me to tell me the same thing. But she can get on my chart and look at her medical records and know it. So rural communities can use data and can use remote patient monitoring. They can use the my charts of the world. I think remote patient monitoring is going to be a huge opportunity. We're getting broadband. We're getting the things that we need in the rural communities. We'll be fine.
Thank you so much.
I shouldn't have said redneck. Sorry. I apologize if I offended somebody.
No, it's fine. Keeping it real. Thank you so much, Terry. This was an amazing presentation. This shows me that we need like 3 more Texas sessions on rural health and rural hospitals. Any final closing thoughts for us or call to actions before we move to a couple quick announcements?
For call to actions, don't forget about us. Don't forget about rural. And there's opportunities, especially with the data and especially with you guys with substance abuse. Don't forget about rural. Rural wants to partner. We need rural to be successful. So especially in a substance abuse, I look forward to seeing what are some of those silver bullets that we can implement across the rural hospitals that you and your team on this call today can help with. So I just thank you for the opportunity for letting us tell the story of rural.
Thank you so much, Terry. So informative. Okay, we have a couple quick announcements before we close out for the day. Team, if you wouldn't mind bringing up those announcements. I know some of you are going to be wanting continuing education credits, and we always like to offer those, a little perk for being here. Today we have both CME available and behavioral health credits and credits for peer professionals. So just complete that survey dropped in the chat there. Note that you need CE credit and you will get your certificate in just a few weeks. Also, we have opportunities to sponsor or exhibit at the Texas Substance Use Symposium. So we're back in San Antonio in 2026, March 2nd and 3rd. Lots of different sponsorship levels. There's something for every organization in there. It's a good opportunity to showcase your organization in front of hundreds of sub-professionals from around the state. So we hope some of you will partner with us on this important event. And I know many of you are already signed up to sponsor, which we appreciate your support. Lastly, sneak peek, TxSUS registration is opening today, really right in the midst of this call. So you're the first to learn of it. So you can register now for, again, that 2-day event in San Antonio on the Riverwalk at the Convention Center. We'll have lots of great plenary and keynote speakers, breakout sessions, hands-on workshops, panels. I know many of you have submitted proposals to speak or proposals for posters. We appreciate that as well. And also we extended the call for posters. So if you didn't get a proposal in on time for a presentation, there's still time to submit a poster if you like. We're going to keep that open a little further into January. So still time. So we hope everyone enjoyed today's session. Terry, thank you again. And we hope to see some of you at the symposium. Thanks so much. Have a great day, everyone.